Welcome to The Spine Guy. I'm Dr. Brian Sue, a fellowship-trained spine surgeon in Marin, California. The Spine Guy is a channel dedicated to making the complex spine simple for patients to understand. Today we'll be talking about something very novel and unique called the cervical disc replacement or cervical disc arthroplasty. The cervical disc replacement for many patients has replaced what we traditionally do, which is an anterior cervical fusion. Now, not everyone's a candidate for a cervical disc replacement, so today we'll be talking about who's a candidate, who's not a candidate, how it may be better than a fusion, some of the risks, benefits, and the typical hospital course for somebody that is going to get a cervical disc replacement. I'll be posting new videos weekly, so hit the subscribe button to catch them as they come out. A cervical disc replacement, cervical is neck, disc is just a disc, and replacement is replace with the same thing that resembles a disc. The easiest way to think about a cervical disc replacement is a total knee replacement equivalent. So when somebody has an arthritic knee or a problem with their knee, it's a mobile bearing joint, it's a joint that moves, so you get a titanium and plastic knee. Well, similarly, a cervical disc replacement is a titanium and plastic disc that allows movement in the neck. The cervical disc replacement is typically an alternative to a cervical fusion. In my practice, I have to have a good reason to be doing a fusion, so I try to do cervical disc replacements if patients are good candidates for cervical disc replacement. And that really is the challenge of a cervical disc replacement, is finding the right patient who's the right candidate. The fundamental principle of a cervical disc replacement is that the patient has to have fairly normal cervical anatomy and a fairly normal disc in order to have the surgery, because you're replacing a normal disc with something that's supposed to function like a normal disc. A cervical disc replacement is very similar to an anterior cervical fusion, where if this is the back of the neck, this is the front of the neck, and this is the oblique view, what happens is we come in through the front, we take the bad disc out, we take the bone spur off the nerve to create an opening, just like the native opening. The surgical approach and what we do technically during surgery, which is to take the disc out, is very similar, in fact identical to an anterior cervical fusion. The only difference is with an anterior cervical fusion, we put bone graft or a cage with a plate and screws. With a disc replacement, we put the actual mobile bearing disc. As patients get older, they get changes in the cervical spine, including disc degeneration, arthritis, etc., as well as changes in postures in the neck. The top 3 contraindications to a disc replacement, meaning reasons you cannot do a disc replacement, is number 1, because of disc degeneration. If the level we're going to do and the disc we're going to take out is significantly collapsed and arthritic over time, then that is a contraindication to a disc replacement. We say that if there's more than 50% height loss of the disc itself relative to a native disc, then you're not a candidate for a disc replacement. The next is cervical facet arthritis. So cervical is neck, and the facet joint is this little joint back here. So what happens is when you move your neck back and forth, there's a little joint in the back called the cervical facet joint. That cervical facet joint has cartilage and is an actual joint and allows motion of the neck. Well, if there's a lot of arthritis in the neck, in the posterior cervical facet, then that is also a contraindication to a cervical disc replacement. I always get a CT scan as well as an MRI. The CT scan and the MRI look at how much arthritis people have in the posterior cervical facets. The last contraindication was very common, is something called kyphosis. This is lordosis, which is the curvature to the neck this way. And that's really what a normal neck should be. As patients get older, as they use their computers and cell phones more, they get tech neck and they start getting what's called kyphosis, which is a flexed forward posture of the neck. Having kyphosis is also a contraindication to a cervical disc replacement. Most candidates for cervical disc replacement, because they have to have a relatively normal neck, are younger patients, typically less than 50 years old, who have a soft disc herniation instead of a bone spur and a non-degenerative neck. There's a joke among spine surgeons that we do more cervical disc replacements if we could find more candidates for cervical disc replacement. And that's definitely true, because it's really hard to find somebody with a relatively normal appearing neck who also happens to need cervical spine surgery. The other issue with cervical disc replacement is that not all insurance companies cover cervical disc replacement, so you'll have to work with your doctor and your insurance company to see if they would cover a cervical disc replacement. So what are the outcomes of cervical disc replacement? They're very similar to the outcomes of fusion, particularly when doing a single level, which is 90 to 95% chance of taking away some shoulder blade and arm pain because we're taking pressure off the pinched nerve, and about an 80% chance of taking away neck pain. Surgery in general is better for treating shoulder blade and arm pain than neck pain, and that's because the shoulder blade and arm pain is coming from a pinched nerve, whereas the neck pain can be coming from many different things. How much pain we take away depends on how badly the nerve's already been damaged. We don't know that till we do the surgery, but in general, we can take away half of someone's pain. It is unrealistic to expect to be totally pain-free in your shoulder blade or arm after surgery because there may be permanent nerve damage that's already occurred. Our hope is to make you better than you were preoperatively. When comparing a cervical disc replacement to a fusion at a single level, the surgeries are pretty equivalent in terms of surgical outcome. Where the game changer really is with a 2-level cervical disc replacement. Now here's one of my patients with a 2-level fusion. So there you see the bone graft, plate, and screws. And here you see another one of my patients with a cervical disc replacement. So there's a metal that attaches to the bone there, another piece of metal here, and there's a free-floating piece of plastic that you don't see on x-ray. Interestingly, all the original studies compared a single-level disc replacement to a single-level fusion, and we really found no difference. So in my patients for single-level disease, I tell them that they certainly have a choice and there may be no difference between the two. However, for 2-level surgery, there have been multiple papers to come out to show that for 2-level surgery, patients can have better clinical outcome with a cervical disc replacement than with a fusion. I've also seen that anecdotally because I do believe that a 2-level cervical fusion does take away a little bit more microarchitectural motion and it causes more adjacent level disease above and below. And we are finding that with 2-level disc replacements compared to a 2-level fusion, there is definitely less secondary surgery that occurs and there may be less adjacent level disease. Adjacent level disease means that by fusing from here to here, this level picks up a little bit more of the slack. It may increase in degeneration, and this level picks up a little bit more slack and may increase in degeneration. Whereas if you maintain normal range of motion at these 2 levels, because of the disc replacement, you offload these 2 adjacent levels. So again, there is some promising initial clinical studies to show that for 2-level surgeries, there may be less adjacent level disease. A 1-level cervical disc replacement from skin to skin takes about an hour, a 2-level disc replacement about an hour and a half, and that time is fairly predictable. It takes a little bit longer than doing a fusion because that cervical disc has to sit just right, and we use quite a bit of x-ray guidance or fluoroscopy to make sure that the cervical disc replacement is well positioned, and that's why it takes a little bit longer than an anterior cervical fusion. A cervical disc replacement is done from the front of the neck. A lot of patients get super freaked out when I'm telling them I'm making an incision in the front to access their spine. But this is the front of the spine. And if you look upwards, there's a muscle here, and there's a little soft spot here between the muscle and the windpipe. And if you push hard, you can feel a hard bone. Well, that bone is right here. It's the C6 tubercle. The anterior cervical approach is one of my favorite approaches because it's very elegant, it's fast, and it's relatively bloodless. There are obviously structures in the way that can be injured, including blood vessels, esophagus, trachea, etc. Injury to those structures is less than 1 in 100 and really exceedingly unusual. The incision for a cervical disc replacement is essentially the same incision as for a fusion. And I make a left-sided incision. This is my patient. We're looking at her. This is the right, this is the left. And you see the incision goes from here to here. She's about 6 months. You can barely see the incision. And in another 6 months, it'll completely disappear. So here it is. I put 2 little pen marks next to the incision just so you could see the size. This is a quarter, and you'll see that's about the size of 1.5 quarters. So it's very, very cosmetic. So once we make an incision, we get down to the front of the spine. And this is what the front of the spine looks like. So this is the cross-section view. This is the patient's right, that's the patient's left. And this is the front of the spine. So here you see the disc here. This is the esophagus and the trachea. We gently retract it to one side. We retract the other muscles and blood vessels to that side. And here we have direct access to the disc. Once we're to the front of the disc, we put 2 retractors in. And then we start taking the disc and bone spurs off the spinal cord, off the nerves here, and we completely decompress the nerve. When we're taking pressure off the nerve in the spinal cord, there obviously is a chance of spinal cord or nerve injury, less than 1 in 1,000. We are watching the spinal cord and nerves the whole time using neurological monitoring, which is somebody that places little sensors, little needles into the arms and legs, so we're watching your spinal cord and we know what's happening even while you're sleeping. There's about a 3% chance of a dural tear, which is a tear in the covering of the nerve. The nerves swim in fluid, and that fluid is covered by a thin sac as thin as saran wrap. If the bone spur or disc is scarred to the sac, as we remove the disc, the sac could tear. If the sac could tear, spinal fluid leaks out, it's not a big deal, we repair it. It delays your recovery by a day or two. It does not change the ultimate outcome of surgery. Once we completely take the disc out, we then have to put in its place a disc replacement. The disc replacement I use is one called the Mobi-C. The Mobi-C has a metal plate on the top that goes into the top bone, a metal plate on the bottom that goes to the bottom bone, and there's a piece of plastic in here that allows different degrees of freedom, twisting, front, back, left, right, and bending, so that you maintain complete motion. So this is a good look at the Mobi-C implant. This is the front back view of it. And you'll see that if I open this up, that there's the top plate that goes on, there's the bottom plate there, and that plastic core is the plastic that goes in between the two. It comes pre-assembled, and the entire unit gets placed into the disc. So you'll see that there's motion like that, and there's twisting, front, back, and lateral bending. So there's complete mobility. This plastic core that's in the middle is a very small plastic core that looks like that. And that plastic core sits on top of that metal plate. And there's two little tabs there, here and here, that prevent it from shifting. When we're putting in the implant, we use our experience, x-ray guidance, neurological monitoring. Despite our best efforts, if the implant isn't perfectly placed, we may have to come back to revise the hardware. Again, we're using x-ray guidance during the surgery, so that's exceedingly unusual. After surgery, there's a chance of infection, less than 1%. The biggest side effect of any anterior cervical surgery is difficulty swallowing. I don't even say that it's a complication, because it's a side effect that we see in every single patient, at least for the first couple of days after surgery. You'll feel like you had your tonsils taken out, because we did have to retract the esophagus. For the first couple of days, patients are drinking fluids, smoothies, applesauce, soup, etc. Most patients at the 5 to 7 day mark had markedly decreased difficulty swallowing, and it's really unusual that I see a patient at the 6-week follow-up where they do still have persistent difficulty swallowing, although it can happen. The real issue with disc replacements long term is not whether or not there's fusion, because we're not trying to achieve a fusion. The real issue is this is a mobile bearing device with plastic in it. Just like total knees and total hips, they don't last forever. So we don't actually know the longevity of total disc replacements, and the dig on total disc replacements right now is that for fusions, we know that we have outstanding outcomes for 30 to 40 years. Well, for disc replacements, at least for 2-level, we now have 7-year outcome, and there is 10-year outcome coming out. The 7-year outcomes look pretty good, but these disc replacements are usually done in patients that are a little bit younger. And so it's hard to know down the road if there's going to be osteolysis, which means the plastic starts to wear out and the disc starts to rotate or move, and these may have to be revised in the future. So the real issue with disc replacement is longevity. Just because you have a disc replacement doesn't mean you won't develop problems above or below the fusion. There is still some rate of adjacent level disease. Right now, we believe for a 2-level disc replacement, there's less of a risk of adjacent level disease than a 2-level fusion. Post-operatively, because it's not a fusion, I have my patients wear a soft cervical collar for comfort just for 2 weeks. I tell patients if you don't use it, you lose it. So I do want them moving their neck within reason, obviously. You do want these metal implants that are here to meld with the bone so it becomes solid. So you don't want to be too aggressive right away. I usually start physical therapy at around 6 weeks and let patients back to the gym at around 3 or 4 months after a disc replacement. Thanks for watching. Hopefully you learned a little bit about cervical disc replacements. Don't forget to click the like button and leave questions or feedback in the comment box below. Feel free to let me know what videos you would like to see in the future.